This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is our Advocacy In Action feature, making our 15th appearance at ASCO and one of our very best. A few of the things we sort of want you to help us spark the topics, and the rest of the panel will then begin to respond. Someone like me who's been lucky enough to actually see a palliative care expert, that was transformational. Having a medical oncologist prescribe an opioid is very easy. You can write a script, but it goes well beyond that. And I worry about when I hear doctors, medical oncologists say, oh no, I'm a palliative care expert, as though there isn't a specialty. And I believe they can coexist. It's frustrating to hear patients believe that if you say palliative care, that means absolute end of life, and now I'm going to die, and they get scared. It's not only value in cancer care, it's value in life and quality life, not quantity life.
So you've given me so many openings, I hardly know where to begin. But I would actually go a step further. The longer I do this, the more I think that the integration of palliative care into oncology is just the definition of good oncology care. That in fact, William Osler, who's sort of the premier physician teacher, said that a good doctor treats the disease, and a great doctor treats the patient with the disease. And in my view, that's really what palliative care is about. It's making sure that the care that we deliver is focused on whatever the patient and family is struggling with. So I would start there and say that our definition needs to be much bigger, and that we don't provide good oncology care if we don't have palliative care integrated. And so we need to pull it as far away from end of life as we can. End-of-life care is probably the domain of palliative care specialists. The integration part is probably something every oncologist needs to learn.
I believe to get over this hump of this fear that the palliative care is end-of-life, is that the palliative specialist or assistant should be there alongside of the oncologist in an ideal world, so that when you receive your diagnosis of metastatic disease, you're told you will have symptoms from whatever I'm going to give you. Or if you don't have symptoms from the treatments, other issues you may have would be quality of sleep. It could be anxiety. It could be pain, joint pain from a very simple medication that you're taking orally, all of the above. And so instead of just going into the examination room and being asked by the nurse, on a level of 0 to 10, what's your pain level? Oh, some of us get so sick of that, because you can say the number, but then, okay, what's the follow-up? So I think it should be part of the team, the metastatic team. It should be made aware that we want to work with you from the early on, and then it be a continuum of services.
I think you raise a big issue, and that is a workforce one. Mm-hmm. We will never have enough board-certified palliative care physicians to see every oncology patient with metastatic disease. And worse, every patient, which is really what I think, because think of how sick we make people with curable disease. I mean, the patients with testicular cancer, we cure them, but we make them 3+ sick along the way. And they deserve good palliative care while they get treated. So I think what we have to do is, as oncologists, take responsibility for learning how to build teams in our office, multi-professional teams, not multi-physician teams necessarily, that provide this care to every patient.
And I think that what that allows you to do is not just focus on people with advanced disease. And I understand why, and I sit on the Sea Change panel, I also sit on the ASCO panel currently, and I understand why we're sort of targeting that particular population, because that's a nice way to sort of ease into this conversation and then move upstream. But if you integrate teams, and that would include mental health professionals, RNs, pastoral care professionals, a broad range of people who have different sets of skills, it sort of allows that dialogue right at that point of diagnosis. So it is, your presenting symptom might be pain, for example, and you might have some anxiety because the doctor just told you have cancer. So how do you introduce the patient and the family, most importantly,
Yes.
or as importantly, to this concept so that as the disease progresses, it's sort of a natural, it's a natural add-on versus an either-or kind of conversation, which is one of those areas that we typically get tripped up in, truthfully.
And I think one of the problems is in medicine, a lot of us learn sort of the see one, do one, teach one model. And there aren't good role models at the moment,
Right.
not enough of them that are oncology and palliative care trained. I actually think one of the bright spots in the younger generation coming up is they care more about this. They really do. That fellows want to hear about this, they want to learn about it, and that makes a huge difference. In spite of this explosion of genomic knowledge they have to get and molecular knowledge, they also care about this. And so what we as a society need to do and as a profession need to do is push this agenda forward so that everyone gets the education and the training that they need, and that we use palliative care specialists, I think, in the same way we use cardiologists and infectious disease specialists, that in the beginning we should all be able to treat neutropenic fevers. And if someone stays febrile for days, we need to call an infectious disease specialist. We should all know how to evaluate and start initial treatment for depression, for pain, but when it's not getting better, we should call the specialist. But it shouldn't be that every patient has to have a specialist for any particular thing. It should be the degree of difficulty that requires the specialist.
I want to make clear that in my perspective, palliative care is not about end of life. In palliative care, we are all going to die. And at some point, I would say most of us in our journey are going to be looking at the possibility of palliative care helping us, whether it's ourselves or our caregiver, people for whom we're providing care. And I think we want to keep it, when we're talking about end of life and when we're talking about palliative care being part of everyone's journey through life, because I think that people are more willing to talk about it at end of life. But I know a lot of people that have orthopedic problems, for example, and have terrible pain and need palliative care, but it's not any way related to life-threatening. So I think it's something we need to talk about as a panel, too.
Well, I think of end of life as palliative care at the end of life. So it's the aggressive palliative care in the last months of life, but it's the whole spectrum. And so I do think it's from the beginning to end. And I think at each stage we need to be teaching doctors how to talk about it and patients how to ask about it, because it's going to take both.
And so one of the things I wanted to point out is this conversation about the importance of individualized care planning from the point of diagnosis. And so to your point about serial therapies or whatever that looks like, regardless of your stage of disease, it's incredibly important to have this individualized care plan where you sit down with your care provider and say, this is what's important to me at this stage, this is what's important to me, maybe as I transform out of acute care into my new normal, whatever that looks like. And I think we all, owe it to the work that we do and the patients we serve to make sure that we continue to support initiatives that support having those sort of documents and regimented plans in place.
I think it is a way to move it upstream, and I don't think it has to cost more. And I think there are lots of little things happening in ASCO that suggest that that's happening. So, for example, the COPI project, which is the quality improvement program of ASCO, now has as one of its core measures that by the third oncology visit, doesn't matter if you have metastatic disease or not, you've addressed advanced directives. That's the right time to talk about it, because we're all going to die. I actually wanted to start a campaign that we all wear buttons that say, I have advanced directives, do you? So I asked all my partners one day at a faculty meeting, how many of you have advanced directives? This is all oncologists. It was less than half by far, and I was floored. So we have to change the culture around talking about it within our profession and then in the public, that this is something we all need to do.
I think there are several things that can be done by each of us, and as you mentioned, you talked to your colleagues. I think there can be little posters in hospitals. Do you have advanced directive? At celebrations of breast cancer, the survivor celebration that we see in October, why we should have sessions about how palliative care played a role in that person's journey, even with early stages, you've pointed out. So no matter what the cancer is, I think there are opportunities for this conversation, and we just have to change the mindset to do it.
So can I just share an example of palliative care that I think sort of lifts it way out of this end-of-life phase? And you know this gentleman well, as do you. But with some of the newer treatments, well, and some of the older treatments, radiation therapy in particular, there are skin reactions that people will experience. And so there is a gentleman now who is a board-certified dermatologist, but he has made his career working with patients who have had skin reactions and helping them live a better quality of life and manage through those type of symptoms. To me, that's an example of supportive care or palliative care. And these are people who are living very productive lives. He works with them alongside their other medical oncologists, radiation oncologists. And it's sort of, you know, I always try to use that example.
Yes, it is.
It's a memorial,
We're
right?
interviewing Mario.
Right?
Yes.
Mario Locatore.
We're
He's great.
interviewing, and he has a fantastic book, and we're interviewing
He
him
does,
tomorrow.
he does. But
he's
to me, that
wonderful.
sort of lifts it out of any of that pain, you know, those sort of end-of-life symptoms. This is something that is right up front. It may be first-line therapy that people experience these symptoms, and Mario is right there helping them along the way. So I always try to use that example to say, this is it.
So in that same vein, that's why I always
Yeah.
talk about antiemetics.
Yeah.
Because nobody gives chemotherapy that causes nausea and vomiting and forgets to prescribe anti-nausea drugs. That's palliative care.
Right.
So some of it is really well integrated,
Yeah.
but there's a lot that has to follow. Thank you.
Dr. Jamie Van Roenn, thank you so much. Shirley Woods, Linda House, Helen Miller from Cancer Care. Thank you all